Good morning. My name is Giacomo Grasselli from Italy, and I have been asked to review the issue of how to prevent trauma-related lung injury. So these are my conflicts of interest, and none of them is really relevant for the content of this presentation. So chest trauma is a very complex medical and surgical event, and as we know, it can be characterized by important damage to both the lung parenchyma, as you can see here, a big pulmonary contusion, and to the integrity of the chest wall. For example, here we can see a rib fracture and the chest drain. So the pathophysiology of chest trauma, of respiratory failure in chest trauma, is quite complex and multifactorial. At the lung level, we can have micro and macro atelectasis due to both parenchymal and bronchial damage. We can have laceration of lung tissue resulting in pulmonary contusion and in air leaks up to open pneumothorax and tension pneumothorax. We can have fat air embolism and hemothorax. And all these derangements result in loss of functional residual capacity and vital capacity, reduction of lung compliance, VQ mismatch, and increased intrapulmonary shunt fraction. Then there are other pathophysiological derangements. First of all, patients may have a decreased respiratory drive in case of head injury. They can have a decreased respiratory muscle activity in case of spinal injury and diaphragmatic lesion. They can have important abnormalities in chest wall motion if multiple rib fractures or flail chest, and also increase intra-abdominal pressure. And all these derangements will result in further compromise in FRC and vital capacity, in reduced compliance of the chest wall, and in decreased peak expiratory flow that results in inefficient cuff. So pulmonary contusion is certainly the most important parenchymal damage. It occurs in up to 1/4 of the cases of the patients with blunt chest trauma, and it's an important predisposing factor for respiratory failure, ARDS, and pneumonia. And we know that isolated pulmonary contusion is also associated with worse patient outcome. Well, this paper that was published almost 20 years ago shows that there is a relationship between the percentage of contusion, the severity of contusion, as indicated by the percentage of lung parenchymal involvement, and the PF ratio at admission, the severity of hypoxemia at admission. And also, the contusion severity is associated with an increasing risk of developing ARDS. We also know that the alveolar arterial gradient, so the difference in alveolar and arterial PaO2, is a poor predictor of the risk of developing ARDS and need of assisted mechanical ventilation. While we know that the most important predictor for the development of ARDS and the requirement of mechanical ventilation is a pulmonary contusion above 20% of the lung parenchyma. This paper has basically compared trauma patients developing ARDS and not developing ARDS, and we can see a lot of differences in patients who develop ARDS that have, for example, more significant compromise of the mental status. They have a higher trauma severity score, but most importantly, they have a higher size of the pulmonary contusion. And again, a contusion size above 24% of total lung volume is the most important predictor of the risk of developing ARDS. There are scores predicting the risk of ARDS and of the need of mechanical ventilation. For example, the RIB score that goes from 1 to 6 that takes into account the number of ribs fracture, the presence of bilateral fractures, flail chest, the type of fracture, the fracture of the first rib, and the different anatomical areas of the rib fractures. And we can see here that the higher the risk score, the higher the risk of mechanical ventilation and of respiratory failure and tracheostomy. The thoracic trauma severity score is another very important score that takes into account different factors: age, PF ratio, rib fractures, lung contusion, and pleural involvement. And this paper, for example, published in Injury in 2016, shows that the higher the TTS score on admission, the higher the risk of delayed ARDS in patients with blunt thoracic trauma. And these are the components of the score. Again, age, PF ratio, the extension of pulmonary contusion, the extension of pulmonary involvement, and the number of rib fractures. It's also very interesting that the diagnostic, the predictive performance of the TTS score in terms of prediction of the risk of ARDS is not related with the severity of hypoxemia at admission. For example, in these patients, comparing patients developing ARDS and not developing ARDS, we can see that the performance of the score is the same in patients with, at admission, a PF ratio below 200 or above 200. There is a very important paper. I think that this is a very interesting paper published by Caroline Calfee and Taylor Thompson. They basically compared patients with trauma-related acute lung injury and patients with ARDS from other etiologies. And they found that patients with trauma-related acute lung injury were younger, less acutely and chronically ill. And very interestingly, they showed that trauma patients had lower level of inflammatory markers of lung epithelial and endothelial injury. And also that patients with trauma-related acute lung injury had lower odds of death, even after controlling for baseline demographic and clinical differences. But what is important, I think, is the difference in the levels of plasma, for example, ICAM1, von Willebrand factor, soluble tumor necrosis factor, and so on. So it seems that trauma-related acute lung injury and acute lung injury from other etiologies are different entities, also from a, let's say, biological point of view. Then let's go to how do we ventilate patients with trauma, chest trauma. This is a systematic review published by Davide Chiumello in 2013 in Intensive Care Medicine that analyzed papers discussing the issue of non-invasive ventilation in chest trauma. And this systematic review shows that the application of non-invasive ventilation in chest trauma is associated with improved oxygenation, decreased respiratory rate, and ultimately decreased mortality. But sometimes non-invasive ventilation is not feasible or not enough, so we have to move to invasive mechanical ventilation. In this paper from the French group, this is a multi-center study that basically aimed to describe the mechanical ventilation modalities used during the first 2 days after the trauma. And the study was conducted in 6 level 1 trauma centers in France. And the study showed that basically in the vast majority of the patients, protective mechanical ventilation was applied even before ARDS occurrence. And the mean tidal volume was around 7 ml per kilo of predicted body weight, and the mean PEEP level was around 8. And again, when analyzing the risk factors for the development of ARDS, they confirmed that the most important risk factor was a lung contusion with an extension of more than 20% of the total lung volume. And also early onset pneumonia was associated with the development of ARDS, while pneumothorax and the number of transfusions were not. So in this, finally, in this paper, the mechanical ventilation settings and rescue therapies have been analyzed, and basically what the authors suggest is that in trauma patients, especially in patients with chest trauma, it's very, very important to implement protective mechanical ventilation. So the use of lower tidal volume ventilation and permissive hypercapnia is important to avoid hyperinflation and ventilator-induced lung injury. So just to remember very simply, in this paper, the authors suggest the application of the RDS network protocol for protective ventilation, which means tidal volume of 6 to 8 ml per kilo of predicted body weight. They suggest the use of standardized PEEP FiO2 tables, but of course we can select any other method of selection of PEEP, provided that plateau pressure and driving pressure remain within protective limits. Also, it's very important the issue of prone positioning. As we know, prone positioning is more and more frequently used in ARDS, and it's been demonstrated to significantly reduce the mortality of the patients with moderate to severe ARDS. Clearly, in trauma patients, prone position can be challenging, but studies have shown that also in trauma patients, prone positioning has the same physiological effects on VQ mismatch and oxygenation. And so in trauma centers, prone positioning is frequently used, and it is safe in the trauma population, as well in patients with who underwent abdominal surgery, provided it is applied in experienced centers. Then a final word about ECMO. You may all know this picture. This is the first paper surviving long-term veno-arterial ECMO, and it was a trauma patient. So this was a young soldier surviving a trauma and who developed ARDS following a severe chest trauma. So it's very interesting that the first case of long-term survivor treated with ECMO was a trauma patient. Clearly, ECMO has a very strong rationale because it helps resting the lungs, so it helps the application, it allows the application of protective or even ultra-protective mechanical ventilation, which, as we have seen, is very important in the prevention of ventilator-induced lung injury in trauma patients. But as we all know, ECMO requires systemic anticoagulation, and so there carries a high risk of bleeding complications. So do we have data from the literature on the application of ECMO in trauma? Yes. This is one of the studies, and this is a multi-center retrospective study on a limited number of patients. So 26 trauma patients treated with ECMO compared with 76 treated with conventional ventilation. And as expected, ECMO patients had more hemorrhagic complications, while controls had more respiratory complications. So during ECMO, protective settings of ventilation were possible. In these centers, they use pressure control ventilation with 12 centimeters of water of driving pressure and 12 centimeters of water of PEEP. And when they matched for age MPF 17 ECMO patients with 17 non-ECMO patients, they observed a significant advantage in survival for patients assisted with ECMO. And ECMO is feasible also without heparin. For example, in this paper, only 3 cases have been described of patients with traumatic brain injury and ARDS who were put on ECMO and kept on ECMO without heparin for 3 to 5 days without major thrombotic complications. So in conclusion, we can say that chest trauma can be associated with very severe respiratory failure and ARDS. And the severity of respiratory failure depends on many factors, and in particular on the extent of pulmonary contusion, rib fractures, and the type of trauma. ARDS is, again, quite likely to occur and frequently requires ventilatory support. Application of protective settings of mechanical ventilation is extremely important to avoid trauma and ventilator-induced lung injury and further lung damage. Prone positioning can be a strategy to improve ventilation and reduce the risk of injury. And also ECMO may, in selected centers, be used to support gas exchange and allow protective ventilation even in trauma patients. And thank you very much for the attention.